Hello and welcome to yet another episode of the AABIP podcast. On the podcast, we discuss interesting and often controversial topics with invited experts on which we usually seek their opinion on how they approach a particular problem. For today's topic, we have decided to pick the brains of an IP giant. Fabien Maldonado is a professor of medicine and thoracic surgery, professor of mechanical engineering, biomedical ethics and society core faculty at Vanderbilt, where he also serves as the IP program director. Fabien, thank you so much for joining us today.
Well, it's a pleasure to be here, and thank you very much for the kind introduction. I am certainly not a giant in IP, but but thank you anyway. All of these other things by serendipity more than hard work. But thank you very much for the kind introduction. I appreciate it.
When Otis was on, I called him a dinosaur, and I called you a giant. So I think with the two of you,
like how I feel right now. Yeah.
All right. So today's topic is going to be approach to tracheal stenosis and benign subglottic stenosis.
Uh-huh.
And for this topic, do you have any relevant conflicts of interest to disclose?
I might. So we're in the process of trying to secure a grant to study Cryospray as a way to prevent recurrence in idiopathic subglottic stenosis. And so that may be an upcoming conflict, which is not finalized yet.
Okay, so, speaking about Cryospray, let's jump into the first question that I have for you. Mm-hmm. So in patients with simple tracheal stenosis, so, somebody who has a short segment involvement, if it's either a scar, a web, a granuloma, but no malacia associated with it, we usually do endoscopic interventions as our first line approach. Mm-hmm. So what tools do you use, and how do you decide what tool to use based on the morphology of the stenosis?
Right. So I think the way you frame this is correct. You have simple stenosis as defined by the absence of cartilage, architectural abnormalities. You have primarily a mucosal and submucosal disease that is relatively short segment. And as you pointed out, I think the vast majority of people would consider some endoscopic management initially, and for good reasons. I mean, there is a significant amount of patients that recur, but a lot of people don't, right? And so even after purely endoscopic dilatation, whether you add steroids with that, the rate of recurrence is about 30% in 3 years, right? This is based on the best data we have from one of my colleagues here at Vanderbilt, Alex Gelbart, who has published a number of papers on idiopathic subglottic stenosis, which is exactly the kind of case scenario you're referring to here, which is a short segment, typically stenosis of the subglottis that does not affect the cartilaginous integrity of the subglottis and trachea. And so because, recurrence are common but not systematic, I think it makes sense to start with endoscopic management. Now, I trained at Mayo Clinic, and I was on staff for, 6 to 7 years after I graduated. And the vast majority of subglottic stenosis there were managed by our ENT colleagues, and were very intimately involved with the management of patients, because we manage the medical treatment aspect of it. And so that management is probably important to point out, because in the large prospective study that Alex published in JAMA, I think a year or two ago, one of the 3 modalities that were evaluated were endoscopic dilatation, and then on the other end of the spectrum, surgical resection. But in the middle, you get this very Mayo-centric way to approach patient, which is essentially an endoscopic resection, which essentially consists of cutting quadrants of mucosa and not dilate, which in that particular study had relatively little recurrence compared to endoscopic dilatation. Now, that's a very Mayo-centric way to proceed. Jens Kasper-Bauer is really the one who's pioneered this kind of treatment. And I'm not aware of other large centers that do that. But this is how I was kind of trained. And when I grew up as an interventional pulmonologist, that's what I saw. And so this is not what the vast majority of us would do, which is rather to use either a laser, like a cutting laser, like CO2, which is great because it doesn't scatter, doesn't cause inflammation beyond the area that you cut. It's very clean laser, or an electrocautery knife, microknife, and do radial incisions to essentially try to direct where the tear is going to happen, because the problem with dilatation is that you're going to have a tear somewhere at some point, and so being able to do these radial cuts really direct where these tears are going to occur, and hopefully occur in an area that's not a big problem, such as the anterior and lateral walls, which are protected by cartilages and not the posterior membranes, for instance. So that would be the way I would approach it, with the caveat that this is probably associated with more recurrence than the procedure that I mentioned earlier. So doing essentially radial cuts, 2 or 3, which are going to be at 12 o'clock, 4 o'clock, and 9 o'clock, for instance, and then use a dilation balloon, a CRA balloon, and just dilate the lesion. And if that works, I mean, if you get a kind of simple web-like fibrotic band that's relatively thin and like I said, is not associated with a loss of integrity of the cartilaginous structure, then you're probably going to be in good shape, at least for some time. Now, whether you add a steroid injection to that, really that's dealer's choice, right? There's not a ton of data, certainly no great data in idiopathic subglottic stenosis, perhaps a little bit more convincing data in GPA, granulomatosis with polyangiitis / Wagner's, artist formerly known as Wagner's. But again, a lot of the data we have in this particular type of disease is pretty anecdotal in nature.
So in your practice, are you using steroids in patients who do not have a systemic inflammatory disorder?
So it depends on the weather, my mood of the day, whether I'm in a hurry or not. I think there's okay data for GPA, maybe some minimal data for post-intubation cuff injury, tracheal stenosis, and probably no data supporting its use in idiopathic subglottic stenosis. So I would use steroids when the patient comes back and there's no good option for a more definitive alternative, such as surgical resection with reanastomosis, and there's a lot of inflammation there. Then I would think about it. Yeah. So typically, Kenalog 40 is what we use, like everybody else. Again, no great data to support this, but we try to do the best. And then we give steroids during the procedure. 8 to 10 of Decadron. And then one thing that we did at Mayo, I keep talking about this because this is where most of my experience was, and quite different than the one I have here at Vanderbilt, where we co-manage actually these patients from an endoscopic treatment standpoint with ENT. I just actually did a case this afternoon, right? That's where I'm coming from. We did a combined case with Alex Galbart where there was a subglottic stenosis in the patient who had prior tracheal resection for cancer without recurrence, and then a left main stenosis. So we do a lot of these cases together, but also co-manage these patients with tracheal stenosis themselves. And so, there's a little bit of variations in how we deal with these. The medical adjunct treatment that folks were using at Mayo when I was a fellow that I got interested in was to add, inhaled corticosteroids like fluticasone 220 twice a day, and then an aggressive regimen of anti-reflux medication, typically PPIs, and then we added, for those who could tolerate it, Bactrim, based on some old data that Bactrim perhaps has an immunomodulating effect in GPA, preventing recurrence, particularly tracheobronchial inflammation. But also there is some suggestion, at least in idiopathic subglottic stenosis, that recurrences are facilitated by bacterial infections, staph infections in particular. And so the idea is that perhaps there is some effect there. And so when I was a fellow, I was kind of intrigued by this regimen. So I looked at the data. We had 110 patients. Back then, it was by far the largest retrospective study on idiopathic subglottic stenosis. And comparing four groups: those that did not have any adjunct medical treatment, those that just had the inhaled steroids, then a group with inhaled steroids and PPI, and then the third group with all three medications. And lo and behold, there appeared to be a significant decrease in recurrence with this tritherapy. So when you look at the JAMA paper that I quoted earlier from Alex Gelbar that was published, I think a year or two ago, maybe it was more recent than that. I have it somewhere. I'll check that. Last year, 2019, the group of patients that belong to that category of endoscopic resection with medical treatment, that's the Mayo experience there. There was 120 patients in that group, so not a huge group, but that was associated with less recurrence. Again, this is all idiopathic subglottic stenosis. So in general, I would say I don't typically do Kenalog on the first go, particularly if you get a bland fibrotic type process without a whole lot of inflammation as assessed by endoscopic appearance. If the patients keep coming back with recurrence and there's no good alternative therapeutic definitive strategy, then I would use it then. And then if I did something in a patient who has active inflammation, which typically we avoid doing that because one of the risks of doing that is to extend the inflammation and potentially cause more trouble down the road, including potentially jeopardizing some possibility of surgical resection down the road. So that's important. So, but if for whatever reason, for symptomatic management, we have to do something and there is some active inflammation there, I'll probably do the Kenalog then as well.
So if I have to just summarize this, so your approach to endoscopic management initially revolves around using a CO2 laser or electrocautery knife to make radial incisions, followed by balloon dilation. And the role of steroids comes in only if there is evidence of endoscopic active inflammation and you use it for recurrence prevention.
And if the patient keeps coming back, right, with recurrence, regardless of, and I should add that I don't use CO2 laser. My ENT colleagues do. I just use the electrocautery microknife. I've used laser in the past. I think the knife is so nice and precise. So I really like this. Yeah.
Mm-hmm. Okay, so you said the use of steroids depends on your mood and the weather, and is it the same with mitomycin C?
Well, no, that doesn't depend on the weather. I never use it. I've never seen this used. I looked at the data before just because I was interested. I mean, conceptually, it makes a lot of sense to put some low dose chemotherapy that's going to inhibit, fibroblastic activity and extracellular matrix deposition. But from a practical standpoint, it's so cumbersome to use these drugs. You got to take a whole range of precautions. I don't think anybody really does this, and if people do, they're rare oddities. And then again, the data is just not there, right? I mean, there's actually a randomized study on mitomycin C. I saw that when I was preparing for this webinar. One applications versus two applications, no difference at 5 years, and who knows whether there's a difference with a control group that didn't have mitomycin C. So, I think mitomycin C is something we like to quote in textbooks and review papers, but not used widely in practice.
All right. So when patients with simple stenosis recur, what is usually your threshold to refer them for surgery? So I guess this largely revolves around the timeline of recurrence, surgical candidacy, shared decision-making. But how do you approach recurrent simple stenosis?
Yeah, I think this is one of the areas in our practice, like empyema management and complex pneumothorax management. And, areas like this where you need to have a really well thought out multidisciplinary approach to the problem, because it is a tough problem. And there's so many factors that need to be taken into account, not the least being, what patients are willing to consider, right, for their care. But, there's kind of extreme case scenarios where you have, patients that are not candidate for surgery because they have so many comorbidities and that it would not make sense. In that particular case, we will continue to manage endoscopically as best we can. escalating the level of kind of aggressive interventions to make them able to breathe and have some quality of life. On the other end of the spectrum, young and healthy, premenopausal females that are, thin and active and want a definitive treatment, for whom surgery is, in my opinion, always the best definitive management. So, again, all the shades of gray in between. And so, if somebody recurs, I typically take one shot at this myself. So I don't have chronic patients with tracheal stenosis and idiopathic subglottic stenosis in particular that I have kept in my personal clinic for years without having at least discussed the case at length with one of my ENT colleagues. Again, we have the luxury at Vanderbilt to have a team that is one of the most experienced in dealing with this type of issues. And so it'd be a shame not to ask them for their opinion to begin with, because I always learn they're doing a lot of translational and clinical research on this particular problem. So there's always, whatever clinical or translational study they're doing that patients may be eligible for anyway. But yeah, there would be a discussion there. And then, because again, if you're able, if patient's a good candidate for tracheal resection, this is riskier than endoscopic management in terms of recurrence. It's dramatically better, right? So again, I keep coming back to that 810 prospective study, idiopathic subglottic stenosis study, but the recurrence rate at 3 years for resection was like 1%.
Only one patient in that study.
Yeah, exactly. So versus 30%. For endoscopic management, and that's a low number. Again, it's perspective, so it's hard to quote other studies that are going to be retrospective. But in our 110 patient study at Mayo, the rate of recurrence at 5 years was 60%, and I think in general that's more in line with what other people have reported. But the point is, if there's potential that is not too risky for definitive treatment that will guarantee the patient to have long-term good outcomes, then why not, right? The only caveat with that is that with regards to idiopathic subglottic stenosis in general, there is a slight increase in voice changes that can be an issue down the road that you don't typically get with endoscopic treatment. So that's something to take into account, particularly in patients who have, we live in Nashville, so we got a lot of, people that are very careful with their vocal cords. And so that becomes a big issue for some people. So, and if that's the case, I don't even mess with it, right? I will definitely have the ENT folks take care of these for me.
So again, if I have to summarize this one more time, so it's usually around the second recurrence where you're thinking that patients may need surgery, but you're emphasizing that multidisciplinary approach to this is the key.
Yes, I think multidisciplinary approach is key, right? So if there's it's always IP, ENT, thoracic surgery, and anesthesia considerations that should kind of draw, and of course, in the center of this group is the patient and what they're willing to consider as part of their, of their treatment. But yeah, I think from the get-go, this should be a multidisciplinary approach to treatment. But for sure, once the patient recurs, particularly if it's going to be an early recurrence or if the outcome is suboptimal. Some patients come in with this bland, thin, fibrotic, web-like, concentric narrowing at the subglottis, and you do radial cuts to dilate, and it looks normal, and they never come back. So there's a subset of patients that clearly don't need a whole lot more than that. For everybody else, particularly when it starts getting more complicated and you get some malacia associated with it and some cartilage abnormalities, then I think really from the get-go, you should discuss this with ENT. We should discuss this with ENT.
So what you're getting to is that complex tracheal stenosis, which is long segment, cartilage damage, malacia, gold standard of treatment is usually surgery in someone who's a surgical candidate. So when I've been seeing these patients in my limited experience, they always come in to the ED. So nobody's doing an emergent surgery on them. When I bronch them, there is really minimal role of cutting something or dilating it and hoping that it'll stay dilated. So I'm invariably placing a stent as a bridge to surgery. Is this something that you see in your practice a lot too, or are you taking patients to surgery quickly or doing something different?
Yeah, so we do that. We use stent as a kind of temporizing. So stents typically will fall into kind of different categories. So you get stents that are needed because there's no possibility of surgical resection and anastomosis, and you need to do something. So you put a stent in, which may be a definitive treatment, with the caveat that these stents in the trachea, as you know, they tend to migrate, right? Mm-hmm. And they tend to migrate on Friday night when you're on call and you get a call at 10 o'clock at night from an outside hospital mm-hmm. and patients in distress, right? It's always like this. And so that's a problem. So in patients like in this particular case scenario, we don't have a great option for surgery for a variety of reasons. There's two ways to try to avoid this. One is to try to fix the stents anteriorly by just suturing it mm-hmm. Anteriorly with a button on the anterior aspect of the neck, or a T-tube if that's the only other option, because then it's anchored there, it's not going to move. The other reason to put a stent in is, as you mentioned, is the idea that yes, there is a potential for surgery down the road, but clearly now is not the right time. They're in the ER and you're going to have to do something. So let's put a stent in as a temporizing measure. I think that's absolutely fine, with the one caveat that the stents, as the trachea moves so much, it extends and quite a bit during the breathing and with mm-hmm. neck movements, and so it causes granulation tissue, and that can become an impediment to a clean and successful surgery. So not uncommonly, surgeons will ask to have a stent holiday before the surgery, and whether patients may tolerate that or not, but not uncommonly they ask for that. There's two other good reasons to put stents in. One would be you get a patient who has tracheal stenosis, but they're also overweight and they have COPD or fibrosis and they're deconditioned and they've got some heart issues. Mm-hmm. And you really don't know what the contribution of the tracheal stenosis is with regards to their overall sense of breathlessness.
So like a stent trial.
So in that particular case, putting a stent in to document that, yes, they do feel better, once you treat the tracheal stenosis, that may be kind of a nice diagnostic intervention that gives you a sense of whether the patient's going to improve or not. Now, there's issues with that, obviously, because everybody feels better after you do some intervention to them. Mm-hmm. You know that from a variety of studies where the placebo effect is huge. And so you got to take that with a grain of salt. But in somebody who's really debilitated and breathless and has multiple reasons to be breathless, including tracheal stenosis, putting a stent in and seeing what kind of impact we have on breathlessness may be a good clue or hint that you may be able to help them by fixing it more permanently. Mm-hmm. The last case scenario where stents are helpful is when you have an early post-intubation or post-trach cuff injury where you have cartilage, fracture or breakdown or injury, like an A-shaped, type stenosis. If it's early enough, we have some data from the UK suggesting that if you put a stent there and you leave it in place, I don't know, I think it's in the study, it was 6 weeks or something like that. Paper from Sendhu looking at post-intubation or post-tracheostomy, cuff injury with cartilage fracture, putting a stent kind of like as a splint almost, to keep these cartilages in the right configuration for a sufficient amount of time, actually allow for healing, and then you might be able to put the stent and have a normal looking or subnormal looking trachea. So that's another case scenario where stent may be useful.
Mm-hmm. So 2 points that I want to pick your brains on what you spoke about. Just the second one first. So the French study looked at patients 12 to 18 months later, Hervé Dutour being the last author on that study, where in patients with A-frame stenosis, they sort of anticipated airway remodeling would happen 12 to 18 months later. So you're saying that early on, there is a chance that, if you put a stent in early, remodeling can happen. And in these situations, it might be worth even just taking the stent out to see how the airway holds. Am I
No.
saying that correctly?
Yes. So I think you're referring to the French study with Hervé Dutot, right? So
Yeah, he was the last author on that. Yeah.
Yeah. So I mean, that's not the study I was referring to. So I think there's a window of opportunity after an acute or subacute cartilage fracture from either cartilage erosion / destruction from the ischemic injury from an overinflated cuff. I think there's a window of opportunity if you stent early that this may actually heal and kind of remodel around the stent. Now, if you have an A-frame stenosis that's been there for 5 years, the chances of that healing in the correct configuration is pretty low. One important aspect of this long-standing A-frame stenosis, which Hervé and his group mentioned in that paper, is that a lot of times you also have a lot of excessive central airway collapse from that posterior membrane, which now has is not quite as tensed as it was, and so you got a very floppy posterior membrane. So what they've done also as part of their endoscopic treatment in this situation, what stent is not an option, is to laser with the YAP the posterior membrane, just like some people have done, like Hervé, really. I mean, he's the one who's done the most of these with Jean-François Dumont at the time, to very superficial burns of the posterior membrane to kind of stiffen it and keep that airway slightly open. Again, that's anecdotal stuff. You got to be super careful if that's something you're considering. I don't think personally that it should be done outside of a research protocol, but that's something that people have done, right, to stiffen that posterior membrane to kind of counteract that. A-frame stenosis-induced posterior membrane hyperlaxity, if you will.
And coming back to the stents and the complications associated with the stents. So I still am trying to figure out what my best practice is. So I've had like 2 or 3 of these patients recently, and given the motion of the trachea or the larynx, and then we know there's a risk of migration with undersizing, granulation tissue with oversizing, which is exacerbated in this area. What I've tended to do is use just not an oversized stent and suture it so that it doesn't migrate and doesn't granulate, but you still have to suture it. So I think in this situation, sizing stents is more important than, in let's say, mid-tracheal extrinsic compression from tumor or something where you have something holding it from the outside.
Yeah.
So how do you size your stents in terms of the diameter and length selection?
Trial and error. I mean, I think that's a tough question to answer. I don't think there's great ways to do that. I mean, you can look at the skin and look at the lumen above and below the area of stenosis and try to get a sense of how a normal airway in that segment that is stenosed would look like. There's stent sizers that you can use, but I've never personally used that. So I will typically, once you've dilated and you're able to go down with your rigid scope, whatever the barrel of that scope is, you probably can add a few millimeters, and that's the size of your stent. But you're right. I think you're kind of between a rock and a hard place. Oversizing it will cause some additional ischemic injury and some inflammation and granulation tissue. And then undersizing it, you're for sure the patient's going to cough it out on Friday night when you're on call, or choke on it, which is certainly worse. And so suturing it is a good, I guess it's an okay option. It's just kind of a pain to do, and B, patients don't really like to kind of walk around with a button, suture to their neck. But that's not a terrible option. The other option would be to use an hourglass stent if you get a focal enough stenosis. The problem is that you do lose a lot of lumen when you do that, right? So you're going to use 16, 14, 16, and all of a sudden your inner diameter is much less. But I think they're a little thicker than the conventional silicone stent that we use. Certainly harder to fold to put in the stent loader. But that's another kind of possibility that will mitigate this problem of migration. But that's the problem with stent for sure. I mean, there's they're going to move at some point or another.
And that's in terms of the diameter. What about the length? How much do you overlap on either side?
Yeah, that's a little bit easier. So, I'll just go from normal to normal on the other side, and I don't typically add anything to that. So, you go down with your flexible scope and you just measure, where does the normal lumen ends and where does it start, and so the in terms of length, I think it's a little bit easier to determine than diameter. How do you do it?
I usually roughly do a centimeter above and below, because it's so rough, like, putting your, having the scope, at the end of your rigid or whatever, and then pulling back, measuring it. I worry about undersizing it. So I usually go 1 centimeter above, 1 centimeter below.
Yeah.
Just to get some margin. But again, my biggest concern is I'm doing this as a bridge to surgery. So if I'm oversizing my stent and causing more ischemic injury, I don't want to convert that disease to a non-surgical disease.
That's exactly right. So, that's a big risk with any kind of endoscopic treatment we do. If you extend the inflammation with cold, hot therapies and debulking of granulation tissue or whatnot, or worse, even with a tracheostomy, or cause more ischemic injury with an oversized stent, is going to compress this capillary circulation, in the wall of the trachea. That these are potential issues that will potentially make the surgeon's life more difficult, if not jeopardize the surgery altogether. So you're absolutely right. I agree with you here.
And then you mentioned about not jeopardizing the tissue with hot therapy, basically heat damage. So have you started using the cryospray? You just mentioned that in the start of the discussion.
So, I've used it. Otis likes it a lot. The cryospray, I got interested in it when I was at Mayo. We had a grant from the company at the time called CSA. They've been bought by a bigger company since, looking at cryospray in the pleural space, actually. So that's what I've used it for before I came to Vanderbilt. And I've used it maybe 4 or 5 times since I've been here for the past 5 years. My 2 colleagues, Otis Rickman and Rob Lentz, like to use it a little bit more than I do. I like to use, stuff for which I have some data, but also, there are some risks associated with the cryospray. It's really under a lot of pressure, and as you know, there's the risk of pneumothorax and barotrauma and things like that. So you got to be careful and follow, the rigorous protocol that's what the company has set in place that mitigate these risks. But conceptually, it's a very appealing technique, right? Because you're going to decellularize the mucosa and submucosa and leave the extracellular matrix intact, so that the idea is that, that extracellular matrix is going to repopulate with healthy cells and potentially remodel that airway with normal cells that will not cause more issues down the road. That's the general idea. And so there is one paper on this, which is retrospective, I think 21 or 22 patients, by Dr. Bora, that was published in, 2015, 2016, something like this, where they looked retrospectively at frequent flyers that would come back for recurrence, and after institution of the cryospray, they tended to come back less. Now, there's all the limitations inherent with this type of retrospective studies, but that's the data we have. And so what we're trying to do is a pilot study where we're going to randomize patients to cryospray plus standard of care versus standard of care by itself, and looking at an imaging endpoint. That's the general kind of idea for the study. And so I'm hopeful that we'll get the funding for this and start recruiting pretty soon. We have a pretty large contingent of patients with subglottic stenosis. We do about 3 to 5 a week. And when I say we, it's 80% of these managed by ENT and 20% managed by us. But that's a fairly large population of patients that hopefully we'll be able to enroll.
So yeah, and Faiz Bora left his cryospray behind when he left Mount Sinai. So I have it in my toolkit, but I've been resistant to using it in patients who don't have active inflammation. So I can't get my head over a fibrotic scar being treated with therapy that relies on water and tissue. I mean, I can understand GPA responding very well to cryospray.
Yeah.
But how about something which is more like scar-like? Would that respond as well? So looking forward to your data.
I think that's absolutely true. I mean, I was just talking today to Alex Galbart, who does a lot of translational and RNA-seq on idiopathic subglottic stenosis, because, as you know, there's a lot of great data suggesting that the histological abnormality in idiopathic subglottic stenosis is primarily a fibrotic one, right? Mm-hmm. I mean, you get a lot of fibrosis, like a keloid-type scar, and not a whole lot of inflammation. But there is, inflammatory pathways that are activated. And when you look at, inflammatory cytokines, they're all upregulated. And so, there is a sense in which, the inflammation really drives the fibrotic response, even though when you take care of patients and they're, kind of become symptomatic and this thing has been dragging on for a while, if you do biopsies, there's relatively little inflammation and a whole lot of scars. So the idea would be that, there probably is some inflammation in there, and maybe you'd be able to kind of treat that with the cryospray and prevent that from recurring. Again, zero data. I'd feel a little bit better when using it when we do have some data to suggest that it's helpful, and hopefully we can run this trial pretty soon.
Mm-hmm. I'm sure what's going to happen is we're all going to say that let's use a multimodal approach. Make superficial cuts and then treat the base with cryo so that you don't injure the mucosa.
Yeah, no, exactly. But in general, less is more with this. Yeah. If you can get away with a simple dilatation with maybe a few radial cuts and that's all you need, that's great.
I've taken enough of your time. If you don't mind, one quick question really at the end. In your management algorithm, do you do anything different in somebody who has a systemic inflammatory etiology to their stenosis? So will you give inhaled steroids, systemic immunosuppression a longer go before you, do something or refer somebody for a surgical consideration?
Yes. Well, so in general, yes. So the, the kind of the typical case scenario would be a GPA patient that comes in with, a flare and they've got, tracheal bronchitis with stenosis, either tracheal and/or bronchial. We tend not to touch these patients in the active phase, actually. Mm-hmm. We'd like for them to be, stabilized, with systemic management, whether, it's rituximab or, Cytoxan. I think rituximab is, since the RAVE trial, the drug of choice, and steroids, obviously, and then manage these bronchoscopically when the lesions have calmed down a little bit. So for GPA, there's no question that treatment of the systemic inflammatory process is going to be very important. The other lesions such as idiopathic, sarcoidosis would be another kind of case scenario, like sarcoidosis of the upper respiratory tract. Rarely you can get inflammatory bowel disease that will give you some tracheal issues, like ulcerative colitis. Mm-hmm. I mean, all these systemic inflammatory condition, connective tissue diseases / vasculitis that can cause some tracheal problem, relapsing polychondritis included, would probably benefit from being managed systemically first and then endoscopically second. And then there's the whole, what I just briefly mentioned earlier of the quote-unquote systemic medical management of idiopathic subglottic stenosis, which, is what we looked at Mayo, and has as good evidence, I think, as anything else we do in this field, where you had a reduction of, with the tritherapy of Bactrim, inhaled steroids, and aggressive PPI, irrespectively of, symptoms and inflammatory markers, that reduced the recurrence rate by half in that cohort. Now, again, this was associated with a different kind of endoscopic management than the one we all typically do. So to be taken with a grain of salt, especially since it's all retrospective data. And just like any of these studies, the number of patients was not huge, but 110 patients in that study. So.
Amazing. Thank you so much, Dr. Maldonado. This has been highly educational for me, as I'm sure it'll be for everyone listening to this.
Well, thank you very much for having me, and Merry Christmas to you.
Likewise, I cannot thank you enough for your time.